My name is Guseman. I'm one of the second-year pediatric residents. I'm currently on pediatrics.
And I'm Judy White. I'm also a second-year developmental.
Our topic today is stroke and ABM. We're presenting with Dr. Rossman and Dr. Pulsipher from the Behavioral Neurodevelopmental Department. So we're going to open with a case presentation. It's a very long hospital course, so we have just the highlights of this case presentation. And hopefully through Dr. Rossman's slides and Dr. Pulsipher's teaching, you can see the meat of what we're trying to convey across with this case presentation. And we have some practice questions at the end to kind of solidify things. So our case is a previously healthy 13-year-old female, no past medical history, who presented with a first-time seizure and some right-sided epiresis in the emergency department initially. So the thought at first was, of course, seizure is presenting symptom. So a workup was done that was generally unremarkable. They did a head CT that was unremarkable at the time. They thought perhaps this was a subclinical status epilepticus type of picture, and for that reason she was admitted actually into the PICU. She was on an EEG throughout the first 24 hours in the PICU, which was unremarkable, didn't show any evidence of prolonged seizure activity. She continued to have neurologic symptoms, including the right-sided hemiparesis, and also was having issues with verbal communication, expressive communication, aphasia. So when in the PICU, 24 hours after admission, she had an MRI, which showed a large left cerebral infarct in the left frontal lobe. So we have some imaging to kind of illustrate that for you. Hopefully you can see that pretty well. I think you don't have to be a radiologist or neurologist to see if there's something that's wrong with the imaging. So looking on the left side, there's the DWI imaging, which shows up at the top this lightened area, and then corresponding to that on this diffusion coefficient, the ABC, you see the darkened area, which having both of those things together in the same MRI, looking through different views, is very consistent with.
I actually think that's not a DWI, but you get the idea. It's probably, we'll go over that, but just kind of sitting with a little bit more caffeine in the system.
Okay.
But we'll chat a little bit more about that.
Okay. So given that this is very consistent with a stroke-like syndrome, so she has these findings on the left part of her MRI, and she has neurologic findings that are consistent with right-sided deficits. So like I said, this was an extensive hospital course for her. Throughout the course of her time in the PICU and then later out of the hospital, she had several complications. She did have a CT angiogram that was performed during the hospital course. It was more suggestive of a dissection, an arterial dissection as the etiology for the stroke, because like I said, she was previously healthy, didn't have any risk factors. We'll talk a little bit more about arterial circulation and that sort of thing with perfusion of the brain for Dr. Rossman. During her prolonged hospital course, she did have a 21-day PICU stay. She had issues with vital sign instability, had increased ICP. She required an emergent craniotomy for that. She did develop also lurch from the DVT. As you can imagine, she was more bound than she typically was prior. She had to start Lovenox, and by the time she was discharged to home, she continued on Lovenox, kept her for seizure prophylaxis, and had extensive physical therapy to address her deficits. So like I said, previously healthy kiddo. By the time they saw her outpatient, it was 3 months post her stroke. She had turned 14 years old at that time. She was having a lot of issues with continued issues with speech. She was only able to utter one word at a time. A lot of the time she would use more nonverbal communication to convey what she was trying to say. And she still had that right hemiparesis. They did some testing, neuropsychological testing, which if you look down at the bottom of the plane shows that she had significantly impaired issues with her verbal communication, expressive language, She still had a lot of limitations with her speech, however, her motor function had improved. Her gait was improved at that time. Still some issues with her, I can be racist, but still a difficulty with word finding. And testing used this time showed that she had some improvement even in some of her communication measures, but however, she's still having issues with executive functioning and verbal memory tasks. We're going to switch over, come back to our questions. Dr. Rossman will talk to you a little bit more in detail about strokes and AVMs.
Can you guys hear me okay? I tend to be loud, so I understand why I sat so far away. I did have breath mints, so if you want to move forward, that's fine. Again, I'm Ian Rossman, I'm a pediatric neurologist. I'm not a stroke expert, I just play one on TV, but I could put together a stroke presentation. And I purposely made this more about stroke in general, and really when you talk about adult stroke, or you talk about stroke, you're talking about adults mostly. Thankfully, strokes are pretty rare in kids. But it's hard to kind of retrofit a topic as broad as stroke and present you guys only on pediatric stroke if you don't even know what a stroke is. So that's why I'm kind of focusing on this neurologic syndrome. For the most part, outside of the neonatal period, pediatric strokes, many of the problems that you see in adults, you're going to see in kids in terms of onset presentation. There are some things that are different about kiddos. So if you walk out of here with nothing other than being able to recognize an acute stroke in anyone from a newborn to 600 years old, then I'll be happy, okay? If you've rounded with me, you know I'm not the most formal human being in the world, so please feel free to interrupt, do whatever you like. So we're going to talk a little bit about these guys, and I did add some pediatric strokes at the end. So what is a stroke? Anyone here? What do you think of when you think of a stroke? What's the first word that pops out to you? Anyone? Bueller. Sudden. Yeah, sudden, exactly. So it's a sudden interruption of the blood supply. Something happens that's different in that moment. And basically, you're strangling the brain for however many seconds to minutes to hours. So it's an interruption of the blood supply to the region of the brain. If that region of the brain is important for something, you're going to have symptoms, right? So it's pretty serious. There's a lot of it. The less healthy we are, the more partying, Mickey D's, and smoking we do as a society, the more you're going to see of this. It's still a leading cause of death in adults, but it's also a very important cause of disability. So not everyone with a stroke dies, and that's important to know that a stroke in a young child, you may be setting them up for lifelong disability, like we saw in the patient you just presented. As we age, we expect to have more strokes and more strokes survivors. Really, I don't care, I'm a pediatrician. But when we think about stroke, we generally think of two big classifications, ischemic strokes and hemorrhagic strokes, and we're going to talk a little bit more about the mechanisms and what they look like. Ischemic is the more common of the two, 75% of all strokes, and it's caused by some occlusion of a blood vessel, whether it's a large vessel or a medium-sized vessel or even smaller blood vessels. Whereas a hemorrhagic stroke is a bleed in the brain. Both can be life-threatening. So what I want you to walk out of here saying is sudden, unexplained, and neurologic. Those are symptoms of a stroke. And I put them in a sun because I realized that spells sun, S-U-N. Sudden, unexplained, and neurologic. Copyright Ian Rossman, feel free to use it. The symptoms of a stroke are anything that suddenly disrupts normal neurologic function. So is swelling of your left knee a stroke? No, right. Sudden inability to speak, yeah, be worried about a stroke. Inability to move, especially things that affect the whole one side or the other. So sudden loss of balance, sudden severe and unexplained headache, worst headache of my life, we'll talk about that. Dizziness, vertigo, uncontrolled nausea, vomiting, things like that. But if it's sudden, unexplained, and neurologic, it's a stroke until proven otherwise, right? All right, sweet. So there's a big push internationally for people to remember fast. Symptoms are the face, the arm, speech, and time. So if you see a facial droop that just came on, what are you thinking of? Stroke. Yes. If somebody can't move their arm or can't hold it up on one side as well, stroke. If they have impaired speech, sudden onset of inability to speak or speak fluently or understand what's being said, think stroke. And remember, time is of the essence. And you may have heard the phrase time is tissue, and we're going to talk about why that is. Anybody here watch the league? Yeah. Just making sure you stay awake. So, pictorially, this is the big difference. In an ischemic stroke, you're blocking off a blood supply to an area of the brain, and that part of the brain, if it doesn't get resupplied the blood, will eventually die, and die quickly and horribly. Hemorrhagic stroke, you also disrupt the oxygenation and blood supply of the brain, but not because you've blocked an artery, but because you have bleeding in that area. And of course, if that blood vessel has ruptured in a certain way, that's going to have certain downstream consequences. And if there's other causes of bleeding, that can lead to infarct as well. So I won't spend too much time on this, but the major causes of ischemic stroke tend to be thrombosis, so causing a blood clot right there, embolism, a blood clot that broke off from one area and traveled to that. Did we have a question?
No, I'm just wondering.
All right.
Showing gravity.
Sounds good. And so we're talking about large vessel territories. So if we block off an entire carotid artery, that's going to look different than if you block off a very small distal branch of like the middle cerebral artery. But you may have heard the term small vessel disease. And so you can have chronic injury to the very smallest perforating vessels that supply areas of the brain and accumulate damage to areas. And that's usually what we mean by small vessel disease. Small vessel disease typically is not a sudden onset phenomenon, though when we talk about lacunar infarcts, that could be. With bleeding, we'll get into that more. Any questions so far? All right. So as we said, this is an area where potentially, you can see down here, can you guys see my mouse? All right. So you might have some blockage here in the internal carotid artery. A piece will flick up and it's going to go, and as long as it doesn't get caught anywhere, it's cool, you're cool, you're cool. Oh no, it's too small. And then what can happen is it can lodge there, and if your body can disrupt that clot, you may have brief symptoms. But if it stays there, and now you've built up a clotting cascade in that area and cause local tissue inflammation, that clot can build and build and build. So you can imagine everything before this is getting blood supply. Everything after this block is not. Okay, and this is depicting a middle cerebral artery clot, and the middle cerebral artery is really a continuation right off of the internal carotid. So you've heard us use some vascular names, vascular territories, and so where the blood vessel goes dictates what part of the brain is going to be injured, and therefore what symptom you may or may not have. And typically we think of three common supratentorial vascular territories: the anterior cerebral artery, ACA, the middle cerebral artery, so up front is the ACA, the middle cerebrals are the largest territory on either side, and then the posterior cerebral artery. Anybody know what phenomenon is associated with spasm in the anterior cerebral artery? I'll give you a hint. You have all had them. I'll give you a hint. You're more likely to have them in the summer when it's hot out. You're eating a giant bowl of ice cream. Brain freeze, ice cream headache. Some people have actually looked and think that it's due to vasospasm of the ACA. So, like eating ice cream will give you a stroke now and in the future. And you can kind of see, this is a cartoon depiction of what the vascular territories look like. And if you look down here, these are CAT scan images. You can see the darkening here. Those are bilateral anterior cerebral artery strokes. This large dark area is that middle cerebral artery stroke. And back here is that right posterior cerebral artery. And sometimes on CAT scan, you can actually see a density, a linear density in that middle cerebral artery. You can see here, you don't see that, but here you do. And that's actually clot that is hyperdense on a CT. Everyone see that? It also helps when you have an arrow sign. You can't miss it. So I did mention lacunar infarcts. This is actually one of the common types of stroke, and probably something you'll see a lot more in adult medicine than pediatric medicine. but these are small areas of stroke that result in damage to these small perforating arteries that come off the middle cerebral artery in the deep gray matter. They call it lacuna meaning lake, because when they did the initial pathology and it looked like there was a little area, a little lake of dead tissue. The body does not like a vacuum, so you often will get some edema or water in there. And so these cause very small ischemic strokes. We usually see this in hypertensive patients. You can see this with thromboembolic events. You're flicking up little pieces of clot, they go to the smallest blood vessels. And there are lacunar syndromes that we'll talk about a little bit later. Most of these occur silently, but you can have symptoms. Symptoms can kind of come and go away. We call that a stuttering lacunar infarct, and that's pretty ominous. That suggests you're at risk for a much larger event later on. This is kind of obvious. Your survival is better with these than with the large vessel strokes. Any questions so far? So remember we talked about time as tissue? Well, that's because the longer your brain goes without oxygen, the worse it is, right? You don't have to be a doctor to know that. And I like this target depiction because this really speaks to the heart of the issue of why time is tissue, because there's the core of the stroke, you think the bullseye, the area where that tissue is toast. That area is the farthest from the blood supply, and it's the area that's going to die most. That's at the center of the infarct. The longer the stroke is on, the longer the blood supply is interrupted, the tissue around that is going to go from being at risk of stroking to having stroke and being permanently damaged. So remember, time is tissue, and we can see that both anatomically and microscopically. So this shows time down here from minutes to hours to days. And here, instead of a bullseye, you really see with this really dark area, is it coming through gray, kind of gray-black? That's the area that's been infarcted. That area is dead tissue. The purple around it suggests that that area is salvageable. So if we were able to intervene right here at time 0, we may not be able to salvage this tissue in the middle, but all the surrounding tissue that's at risk, we can save. So obviously you want a tinier stroke than a big stroke, right? It's not time to go big or go home. So over time, that area of dead tissue will expand, and what we call a completed stroke is a stroke that cannot be reversed, that cannot be salvaged. All right? So this is a little bit small, and I'm not expecting you to memorize this process, but what I really like about this, I'm a nerd, so I like a lot about this. But again, you've got time on the x-axis here, and if you look down here, you have salvageable tissue getting less and less and less and less, and you have loss of therapeutic benefit. This right here is the whole reason why you can't treat a stroke, or you shouldn't treat a stroke, after 6 hours, because the risk-benefit ratio of the clot-busting meds goes backwards. If you intervene very early, you have a lot to save. But if all that tissue is already dead, then you don't have a lot to save, but you still have all the same bleeding risks of that clot-busting drug. Does that make sense? What I like about this is these are all the things that are occurring on a microscopic level that mediate the cell death pathways of the tissue that's already infarcted and the tissue that's at risk. And if you look at this time here from 0 to 4.5 hours, this is the true therapeutic window that you have. And they say the realistic window up to 12 hours. We usually say up to 6 hours for the TPA type drugs. And certainly longer if we're going in endovascularly to retrieve that clot. But you can see that if you're intervening at 4.5 hours, all of these fun pathways that you've learned about in biochemistry and completely forgotten have been going on in the areas at risk. And this is why, even if you restore blood supply, you don't go back and save that tissue. And in fact, does anybody know what it's called when you revascularize and allow blood supply to the brain and have further injury? Does anybody know what that's called? Reperfusion injury, exactly, because now you're providing oxygen back to an area where there's already this heavy level of oxidative stress and all these survival pathways. So that may kick off apoptosis and further excitotoxicity in already irritated regions of the brain. Does that make sense? All right. What is a TIA? I love people go, mini stroke, oh, it's so cute, it's just a little stroke, you know? So TIAs are a big deal. TIAs are stroke. It just so happens that either that little area has been revascularized. I can't say that word, so I'm just going to stop. It got its blood back. So the clot was busted up because our body does not like clots. And I always learn about clots thinking, oh, they just sit there. But they're really dynamic things that are happening. The body's trying to form more clot, because that's what it does on a clot, while it's trying to bust it up. So sometimes you'll have a little wedge of embolus or a thrombus form. You start to get symptoms, and then the symptoms go away. If they go away within 24 hours, we typically call that a mini stroke or a transient ischemic attack, TIA. However, if you do an MRI, and that MRI shows DWI and EDC changes, even if the person's completely asymptomatic, guess what? Take mini away. That was a stroke, all right? And TIAs are very important because sometimes they act as early warning signs for somebody to have a very large clinical attack. So my favorite part of stroke is the neuroimaging of acute stroke. Why do we do a CAT scan as first line? Who can tell me? I hear whispers.
Make sure it's not hemorrhagic.
Excellent! 10 points to Gryffindor. So, you don't want to give somebody a clot-busting drug if they're sitting with a giant, puddle of blood in their head. So really, having, somebody comes in with sudden, unexplained neurologic symptoms, right? And their CT is normal. You don't say, well, their CT is normal, let's go have a beer, right? That's the first step. You've ruled out the minority of strokes. So early on, within a few hours, the CT should appear normal. If you start to see changes on a CAT scan, that's suggestive that that person has completed the infarct in that area. So that's area that is no longer salvageable in all likelihood. Okay. So usually on CAT scan, you'll see, and I don't know how well this projects. This looks normal. You see some gray-white differentiation. You see the presence of sulci. Here, because we have the arrow sign, if you really squint, you might be able to see that this area is a little bit darker than this area, and it's a little bit harder to make out the white and gray matter. You guys kind of agree? All right. You should not miss this even from the back of the room, right? This hypodense area is an area of the brain that has been infarcted, that's dead tissue. If you see that when they come in for their initial CAT scan, the game is over, essentially, for that area. Now, that doesn't mean you just stop doing what you're doing, because what if it's a huge stroke, and you can still save this whole area? Or what if they also have a stroke on the other side, or in one of the other territories? So what I'm saying is, don't just stop and get a beer after you do an initial CAT scan. There's more to do. In the adult world, they do a lot of vessel imaging simultaneously with the initial CAT scan, because a CT angiogram is very, very sensitive for picking up vessel occlusion. So the gold standard in adults is a large, 18 gauge IV, send them in, do a CT with contrast, and look to see if you can do an intervention. In kids, we try not to irradiate them so much or shut down their kidneys so much. So we often try to go right to an MRI or an MRA. There is something called the hyperacute MRI protocol that you can bypass that CAT scan. If you're set up to do it, I'd say go ahead and bypass the CAT scan. Even if you're kind of set up to do it, I'd say do the CAT scan. You can get it quickly, you can move it around. You want to rule out that hemorrhage before you do anything else. MRIs are awesome because you can start detecting changes to the tissue within minutes, essentially. So if you have a kid who's sitting in front of you who is fine, and then all of a sudden they're hemiplegic and their face is drooping, sudden unexplained neurologic, you want to get that CAT scan. But honestly, the CAT scan is going to be negative for acute ischemic stroke. If you can get them right to an MRI, even within those few minutes, you'll start to see those DWI changes. All right, and we're going to talk a little bit about the difference between restricted diffusion and perfusion. So here, once again, you can see on a CAT scan of a completed right MCA stroke, there's the MCA territory. Notice the ACA area and the PCA is fine. You can already see swelling over here, and strokes cause a lot of edema, and MCA strokes do lead to a lot of edema. Often you have to do a rescue hemicraniectomy. You can already see this pushing into the ventricle. Check out this piece of spaghetti here. It just ends right there, whereas on the other side, it keeps going and branching off. This is an example of a CTA showing that large vessel cutoff. So this would be a right MCA infarct. So you've heard us talk about diffusion-weighted imaging in acute stroke. So essentially, what is diffusion? Who remembers back to 8th grade?
Something moving from high concentration to low concentration.
Okay, yeah, so and specifically water. Diffusion refers to the movement of water across the membrane. It typically wants to move to balance out concentration. So water is super important, and in the brain, our brains are mostly just water and fat where they're supposed to be. It turns out that MRI is very sensitive at looking at water in different ways. And when you remove the energy source to brain cells, they can no longer move water well. Their diffusion ability is restricted. So you get what's called restricted diffusion. Make sense? So this is a CAT scan on top, and this is a DWI image. And on DWI, you see brightness. It's not a very good picture for looking at anatomical variants. It's a little bit fuzzy, but you get to see this beautiful area where the diffusion has been restricted. So if you do an MRI and I'm not around and you see bright on DWI, you know that there's a problem there. Okay. It turns out that you need more than just the DWI. You need to see brightness on DWI and corresponding darkness on the apparent diffusion coefficient. And together, if it's bright here and dark here, bright here and dark here, you know that's true restricted diffusion. And you can have restricted diffusion not just in stroke, but in inflammation, in infections, and other conditions. But not all that is bright on DWI suggests that it has to be an acute event. So if you do an MRI and you see a T2 image, who remembers what T2 shows you? Who's rotated with me? What's bright on T2?
H2O.
Yes, that's right, water. H2O, T2O. So T1, water is dark. T2, water is bright. It's not what you'll remember. You'll see early on, the T2 image, there's not a whole lot of standing water or edema in the tissue just yet. But over time, you'll see that this area gets brighter and brighter on T2. Makes sense? But in the acute phase, you need the DWI to show restricted diffusion. This is a molecular event that the MRI is able to pick up. So within the first 24 hours, you see that the DWI goes up, and that signal will stay up for a week. In some studies, they suggest up to 2 weeks in adult brains. And by adult, I mean over age 2. This kind of goes out the window a little bit in kids who are very young, infants, especially newborns, because their brains are so much more watery. And so you can lose the DWI signal within about 5 to 7 days. But in adults, this DWI signal will stay bright for about a week or 2. And that corresponding ADC signal will get dark over that interval. Does that make sense? So if it's bright on DWI and dark on ADC, it's a stroke. Yeah, you got it. All right. So we talked about restricted diffusion. So that's how we make a diagnosis. But what we're really worried about is perfusion, right? The whole point of the blood vessels are to bring blood to perfuse the brain. And so it turns out that early in a stroke, what you might see is an area of restricted diffusion. Remember that number, the middle of that target. And that area, that purple area around it was at risk. And we can use MRI, we can use CAT scan too, but in this day and age we mostly use MRI to show that this area of restricted diffusion may not be the whole story. And so you can kind of see this darker, this greener area out here. Does everyone see that? This is looking at the ability of the brain, this is looking at the perfusion of the brain. And if this diffusion injury does not match entirely with the perfusion injury, this suggests that there's a diffusion-perfusion mismatch. This is a setup for us to do something to help this person. Okay? So DWI, that's the area that area of the brain is already toast. This area is getting toasted and we want to untoast it. Does that make sense? So we can use our imaging to make a therapeutic intervention. Now, some of these therapeutic interventions have been studied in kids, some have not. But if you are set up to do what's called endovascular treatment, where they go in through the blood vessels, it can go in and retrieve the clots or deliver the clot-busting medicine right to it. You can take somebody who has a dense hemiparesis, a very, very severe stroke, and within hours they can be essentially back to baseline. So it really is remarkable. If this perfusion mismatch persists for many, many, many hours, you may be able to do this 12 hours after the initial event. So this technology has allowed us to make interventions right away and know what we're hoping to save. It also, in many ways, can extend the time that we can intervene in a stroke. And conversely, this may also tell us that doing more is more likely to harm the patient. Because if the diffusion and the perfusion match, then our interventions are not able to target any spareable tissue, receivable, salvageable tissue. Does that make sense? All right, any questions on ischemic stroke? The high of the bald guy starting to wane, people's lunches are kicking in, we're getting sleepy. So, does anyone else think this looks like Greg? Is he here? All right, that's too bad. All right. So not that I want him to have a hemorrhagic stroke. So, let's talk about hemorrhagic stroke. This is just a bleeding event in the brain that is interrupting oxygenation of the brain. Okay. Very often this is due to something that disrupted or broke the blood vessel in a certain way. So there are a lot of similarities in terms of presentation of ischemic and hemorrhagic stroke, right? Sudden, unexplained, and neurological. I'm going to say that till somebody vomits, okay? So the one thing to remember with a hemorrhagic stroke is people look sick. People will often complain of a severe headache. The term worst headache of my life often comes up in a lot of board questions about subarachnoid hemorrhage and things like that. So sudden worst headache of their life, and also things deteriorate rapidly. So with a ischemic stroke, the symptoms come on and they tend to be dense from the start. They may get better, better, better. Hemorrhagic stroke, things get worse, worse, worse. Okay? Nausea and vomiting, signs of increased intracranial pressure, neck pain, especially if there's a dissection and rupture, there's irritation of the meninges because of blood, and so phonophobia. So if you have a person who has migraines and they come in with their worst headache of their life, and then light and sounds bothering them, and they're vomiting, should you be worried about a hemorrhagic stroke? Every single person with a bad migraine, you're worried about hemorrhagic stroke? No. Right? So if somebody is a known migraineur and they come in, they're like, oh yeah, my head hurts, and then they're texting, chances are they're not having a hemorrhagic stroke. But if they look sick, they have weakness, if they have, things that you can elicit on exam, problems with balance, neck pain with these are the areas where I'd be a little bit more concerned about hemorrhagic stroke, particularly if there's a setup for it. So if you have a renal patient who comes in with a hypertensive emergency and they all of a sudden have a sudden onset of severe headache and all the symptoms, you can think hemorrhagic stroke. I'll never fault you for getting a CAT scan in a normal-sized human being who, if you say, I was really worried based on X, Y, or Z about hemorrhagic stroke, you get a CAT scan, you're cool. All right? Oh my gosh, what is that? Hemorrhage, right? So blood is really bright on CAT scan. It's bone bright. So we've got the bone out here. We've got this bright blood signal. So CAT scans are super duper duper sensitive for acute blood. You also see some edema around here that's dark. So we do a CAT scan because this is what we're looking for and hoping not to see in anybody, right? You can see that the blood is taking up space. There's a midline shift here. It's pushing on the ventricle. This is not a happy brain. Blood may be a little less in your face than this giant basketball sitting in someone's frontal lobe. If you look over here, you have normal subarachnoid spaces. You see the dark is water signaling is dark. And here, it's all bright white. This is subarachnoid blood that is tracking around, around the subarachnoid spaces. Does everyone see that? Okay. Questions on that? So this is my favorite part of stroke, itty bitty baby doo-doo. If you can remember this, you pretty much remember everything you need to know about stroke. This is about imaging on MRI and blood. So this is a mnemonic for remembering what blood looks like on T1s and T2s. So when you read a radiology report or an MRI report and they say there's subacute blood here and chronic blood there, or we're worried about a subdural where there's acute on the chronic, you say how the heck do they differentiate all these things? MRI helps us do this. So the timeline here is hyperacute, acute, early subacute, late subacute, and chronic. And this is really confusing at first, but less than 7 hours is hyperacute. 7 hours to 3 days is acute. 3 days to 7 days is early subacute. 7 days to 3 weeks is late subacute, and the chronic is greater than 3 weeks. And the mnemonic is it be itty bitty baby doo-doo. If it's iso-intense and bright, that's it be. It's iso-intense on T1, bright on T2. Okay, you know that that's hyperacute. This is something that just happened within the last few hours. If it's iso-intense on T1 and dark on T2, then you know it's acute blood. If it's bright on T1 and dark on T2, it's early subacute. Bright, and dark. Does that make sense, kind of? Maybe, sort of? Let's put it into action. So, it be, itty bitty bitty. So this is an acute and subacute hemorrhage, right? So, what kind of study is this? CAT scan. Yeah, it's a CAT scan. And you can tell because the bone is super bright and blood is bright, right? What's this? It says it down there, guys. It's a T2, right? So you know it's T2 because water, the ventricles, are bright, right? H2O, T2O. So we said this was acute blood, right? And this is dark. What is it on T1? It's itty bitty baby. I can say baby doo-doo all day long. So we've got iso-intense and bright, iso-intense and dark. Ooh, wrong way. Iso-intense and dark. So what is this? It's acute blood. It even says so right here. All right. I should have brought coffee for everyone. I'm sorry, it's my fault. So this is an example of how you can use your imaging modalities to date or to check the age of the blood. Does that kind of make sense? I want to unpack the mysticism that comes with the imaging reports, and I encourage all of you to look at all your imaging, no matter what it is. It could be a CAT scan of the abdomen or MRI of the brain. You know, it's your job to look at these things for your education. Plus, it makes medicine more interesting. Anyway, questions on itty bitty baby doo-doo? We can go over this another time. I know I had to learn this about 800 times. I was just teaching residents a couple weeks ago and I still screwed it up. Anyone there for that? So it's okay to make mistakes. So I wanted to quickly talk about venous infarcts because these occur and there are some very specific circumstances where you're going to see this and there may be board questions about this. So when you have a thrombosis in the cerebral sinus venous, you can have stasis and you can disrupt blood supply to the brain for a few reasons. Venous infarcts are actually very, very, very hemorrhagic. So you may have a hemorrhagic infarct due to an underlying sinus venous thrombosis. But also, as you get more and more stasis of the venous blood and more buildup, you disrupt that oxygen exchange that occurs at the capillaries, and then you can have areas of infarct as well. So if you see non-arterial territory blood vessels, and especially if you see signs of blood, pooling in the veins, you should be thinking venous infarct. Risk factors you may know about are anything that increases your hypercoagulable state, oral contraceptives, inherited thrombophilia, so on and so forth. My favorite sinus venous thrombosis story was in an 18-month-old boy who came in, altered mental status, complaining his head hurt, saying hurt, hurt. Kid was pale as a ghost. His H&H was something like 5 and 15. Anybody have a clue as to what was his risk factor for being so anemic? I'll give you a hint. He was a picky eater. But there was one thing he loved. Milk. This 18-month-old was drinking like a fraternity stunt amount of milk a day, and he was so anemic from milk overconsumption that he actually had a cerebral sinus venous thrombosis. It was pretty intense. This is imaging to show you what the normal veins in the brain are supposed to look like. And this breaks it up by the most common areas. Superior sagittal sinus is by far over half of sinus venous thrombosis, so I'm not boring with the rest. But these are areas of thrombosis that you often see, and these are areas of tissue that are often impacted where you see infarct if you see a venous thrombosis. So sagittal sinus venous thrombosis. The vein of Labbé comes off the side here, and this is where you'll see infarct territory. So this could be a little bit confusing with partial MCA territory infarct. Any questions on that? Am I just thoroughly confusing the crap out of everybody? All right. Any questions on stroke before we move on to AVM? Did anybody attend Dr. Chen's talk on AVM? Good. So she'll have done a way better job than I'm about to do, but at least you guys are primed. So who can tell me what an AVM is? Arterial venous malformation. There you go. So you all know, not just the brain, but every part of your body, the way we oxygenate our tissues is the arteries bring oxygen-rich blood. There's an area where they come together with the blood vessels that are going to take them away. And what is that little area between? What do we call those guys? Capillaries, right. So an arterial venous malformation, by definition, involves not just arteries and not just veins. It's the intersection between the two. So you get abnormal tangles of high velocity arterial blood vessels and low velocity venous blood vessels. So it's a developmental issue. There are genes associated with risk for AVMs. And this is often something that somebody will have and not know about until it's a problem. So it's important to remember that, that high flow arteries are built one way and low flow veins are built another way. So if you do pathology on this, you expect to see mixed blood vessel types, not just all arterial structures, not all venous structures, not all capillary structures, okay? And what you often want to look for, whether it's on pathology or it's on imaging, is something coming in that looks arterial-like and something coming out that looks venous-like. And that's one way, that's a clue that, hey, maybe this is an AVM. Does that make sense? I think AVMs also are shrouded in mysticism because they sound like, ooh, what's an AVM? But it's in the name, guys. It's an arterial venous malformation. Mic drop, you're done, right? So, and this is a problem anytime that you have high flow arterial blood shunting over to a low flow venous blood. So if you see on pathology, I don't know if you guys have, do you have pathology on your boards? Is there some? Yeah, so this is one that I'm not great at pathology, but even, I'll remember, oh yeah, look, there's arterial structures and venous structures, okay? And then the most important thing is that there's normal appearing brain tissue in between, and that'll help differentiate this from a cavernoma, which we'll see a little bit. How are we doing on time? So symptoms of AVM are like anything else, location, 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 and size. So most are asymptomatic. Again, they're not a problem until they're a problem. But because you have abnormal blood supply, you can have areas of injury, areas of irritated brain, you can have cortical malformations associated, so you can have seizures. And sometimes we'll do imaging on a kid with seizures, especially focal seizures, and lo and behold, they'll have an underlying AVM. You can certainly have stroke-like symptoms, particularly if there's bleeding. And there is an annual risk for bleeding. So just because something is asymptomatic, the decision not to treat is based on quite a few things. One thing you may be able to defined as a bruit on exam. Where should you listen for bruits? Let's say on a 12-month-old who you're afraid may have an AVM. Where should you listen? Anyone? So you're going to listen to the heart, right? That's an easy one. Somebody should have called that. So who's seen me examine a baby? So I look nuts, right? Because I listen to the heart. You guys have seen me this week. I listen to the neck, right? And I listen over the fontanelle. And then over the eyes. You can also listen over the mastoids. So if you hear bruit here, you definitely want to listen all over the place. This may just be a venous hum, but if you hear a bruit in the over the fontanelle, you should be very concerned about an AVM in the brain, especially if it refers to the bony structures, the mastoids, and the over the eyes and everything. If you pick it up, again, you will look like a rock star. So what do they look like on MRI? Well, this is where I can never see food-related analogies, but people say there's a popcorn-like appearance sometimes. I don't know. But what you can see is areas of high flow and low flow. And on T2, arteries that have high flow blood will look dark. So these areas of dark are what we call flow voids on T2. So this is a clue that these round and tubular structures that are dark on a T2 where water appears bright are areas of moving blood, okay, an artery. If you look on an MRA, you'll see the large blood vessels, but you'll also see, coming off this middle cerebral artery area, an area that looks a little bit cloudy and funky. That ain't right. See? Compare this side to this side. This side has a nice flying spaghetti monster appearance, and this side does not. Okay. I think, I may be overstating it, but I think over here may be the draining vein, but this little smear here, but let's put a pin in that. So if I were a surgeon, I'd want to know whether or not I should take this out. And they do have a grading. I don't know, did Dr. Chen go over this a little bit? Okay. So essentially the decision to or not to remove things are how big, bad, scary it is it somewhere where it's causing problems, and whether or not you're going to cause more harm than you're going to fix. This is what it looks like surgically if you go in. So here you've got a feeding vessel. You can see a very, very, very large one. It may be very difficult to take out something like this. So for more information about this, definitely talk to Dr. Hughes or Dr. Chen. It may be that a surgery is the safest and most effective way to give back quality of life. There are minimally invasive ways to treat AVMs. Again, you'd have to talk to them a little bit more about it, but I think it's neat to know that if there's something for which a surgical option may not be viable, there may be the stereotactic radiosurgical option. Has anyone ever seen the helmets that you go in for one of these guys? It's very claustrophobic. So there are people for whom this may be the right procedure, but they're not going to tolerate it. Any questions on this? Again, this is more adult stuff. The last way is, or another way is embolization, where they go in endovascularly and they're able to block off the blood supply, essentially clot off or stroke out this AVM. They can also do this with metal coils. So once you have metal coils put in your brain, can you get an MRI? No. That's why they ask for aneurysm clips and coils. This may make it easier to do an open surgery later on and shrink the AVM as well. And they may have to go in more than once and do more than one embolization. Okay? I thought this looked like Hillary Clinton. So. Right? It was by accident. So let's talk brain aneurysms. Hillary Clinton does not have a brain aneurysm that I know about. I couldn't cast that up. So a brain aneurysm is an outpouching of a blood vessel. They tend to happen at branch points. That seems to be an area that's weak. The ones in the posterior circulation are the ones that are more likely to rupture. You may have heard of saccular or barium aneurysms. What's that common in? Barium aneurysms.
Anterior communicating.
Well, I'm sorry, what syndrome that you guys may see? Is that similar? Yeah, there you go. All right.
the reason we care about brain aneurysms is sitting there, they're probably not going to cause symptoms, but if they rupture, bet your sweet bippy they're going to cause symptoms. Aneurysms, as they get bigger, tend to be more symptomatic. So this shows kind of where you're more likely to have red is bad, white is less bad. So areas of branching tend to be areas, and who said, I heard somebody whisper anterior communicating, and points to, like, I guess Gryffindor again. So yeah, so those tend to be an area about 30%, tend to be anterior. Anterior communicating rather, but honestly, you can have aneurysms anywhere. Things to remember when you have a ruptured aneurysm, it's a sudden event, and this is where people report that thunderclap or worst headache of their life. Unfortunately, everyone uses the term worst headache of their life now, so it's kind of gotten diluted. But if you see meningismus signs, they're afebrile, severe headache, they've got blurred vision, double vision, any pupillary abnormalities, sensitivity to light, loss of sensation, I will not fault you for getting a CAT scan. All right. Any questions on aneurysms? I know we're starting to move a little bit faster because we're almost out of time. Anything else? All right. Developmental venous anomalies are not a problem. They're a problem that we pick up because we have great MRIs. You will never see one look this good. But essentially, these are venous anomalies. They typically do not cause any problems. And you'll see a feeding vessel and this caput medusa-like appearance with contrast. I have never seen one look this gorgeous except for on a Google search. The reason we care is about 20% are associated with cavernous malformations, and those we'll refer to as mixed vascular malformations. DVAs are something that we image, we make sure everything's okay, we don't do anything else now. Okay. So cerebral cavernous venous malformations, or cavernoma. These can happen in isolation, they can happen as part of a familial syndrome or all over the brain. They can be ginormous, they can be tiny. These are large, dilated, thin-walled vascular structures, right? These are not arterial, they're small venous malformations. You can see them on pathologies, these sinusoidal, blood-filled areas, and there's no normal-looking brain in between, okay? So AVMs, normal appearing brain stuck between abnormal blood vessels here, there's none. Oh, I'm sorry, these have the popcorn appearance. I apologize for misleading you. I still don't see it. So. But the important thing is here, this is where you can really let your itty-bitty baby doo-doo kind of shine, where you can see chronic and acute blood. This is SWI imaging. This lets you look for blood product. Blood product appears dark, and you can see in these familial forms, you can have them all over the brain. That's pretty gnarly. Did you want to go over? Okay, so I'm just gonna, you guys can get these slides and look at the different syndromes. Cerebellar syndrome, the one thing I want you to think of is a sudden, unexplained, severe nausea, vomiting, and vertigo that is terrible whether you're laying down, sitting up. Really think posterior circulation stroke. I got burned in residency a couple times for that. Especially if it's somebody who has hypertensive or any other sort of history that makes it easier to bleed in the brain. Okay. So very quickly, because we're pediatricians here, right? Pediatric stroke. Stroke, thankfully, is rare in kids, but it does happen. And you should think of ischemic arterial strokes in kids who've had congenital heart disease, sickle cell patients, or other hemoglobinopathies. Anything that's disrupted the endovascular system, so infection, traumas, things like that. Somebody comes in with an MDA, dissection, things like that. Moya moya is something that you can read more about. I didn't really go into it on this one. But if there's a known history of moya moya or any other vasculopathy, you should think stroke. We tend to think too much about mitochondrial disease here, just because we're lucky enough to have Bruce Cohen here. But certainly, metabolic strokes are more common in kids in whom it may be a first presentation of a mitochondrial disease. Hemorrhagic strokes, especially in the newborn period, are common, and then ruptured AVMs are a common cause of hemorrhagic stroke in kids. Perinatal stroke is probably what I want you to think about most when you're on the floor. Is if you get called to the NICU for a child who's had a seizure, A newborn with a seizure is a stroke until proven otherwise. There may be some maternal as well as fetal and neonatal factors that increase their risk. There may be some other genetic factors, but you don't have to care. You don't have to know what caused it. If you get called to the NICU for a newborn that's having a seizure, think stroke until proven otherwise. Okay. So should you call me for a continuous EEG? No, you should get some imaging first, then we can talk EEG. Okay? Oh wait, did I mention that? Stroke in a newborn? Seizure in newborns is stroke until proven otherwise. Right. And just remember, prenatal and perinatal strokes are 17 times more common than other pediatric strokes. Anyway, I'm over. Any questions or concerns? Did I thoroughly confuse the heck out of you? All right, good. I did my job. All right. If you have more questions, you guys think about it afterwards. I think you guys answered your questions.
We had a couple questions, but I don't know if we really have time to kind of go
Yeah,
through
probably
since
not.
they're looking to come in.